thoracic spine. The technical term for this is kyphosis. And he's not able to come out of this flexion, and so this is interfering with his movement. Primarily, I think the reason for
here with an overview
this
of
happening
fascia,
with
and then
him
we'll go into more detail
is
in later
the
segments.
scar area here from where
As
he
the
had
first cells
cancerous
divide
tumor
from 1
removed.
to 2 to 4 to
And
16,
that, I
they have the
believe, is
form and
impinging
structure
on his
similar to a
ribs.
ball of cotton. The
So
fabric of
let's
this cotton ball is
lay him
collagen and
down and
elastin
talk a little
fibers
bit
suspended
about
in a gel
ribs and how
called
to work
ground
with them.
substance. This is the early formation of the fascial network. As the embryo further develops, pockets in the fascial network will attract various specialized cells. Where the tension in the network is greatest, osteoblasts will lay down calcites. In another area, myoblasts will lay down muscle cells. The nerves and blood vessels will move through the fascial network following tracks described by tension in the fascia. Because of this uniqueness of the fascial tension to each individual, there will be differences in where our nerves and blood vessels are, how our bones and muscles are shaped. Throughout this fascial network, a continuity will be maintained, with no real separations between a bone, muscle, nerves, etc., other than the type of cells that make up each type of tissue. When we look through anatomy books, it seems as though there are clear separations between the various components of the body. Reality is a little more disorienting, as there is no clear separation between the segments contained in the fascial net. This lack of clear separations in the body is a function of the lack of real distinction in the fascial network. With the exception that there is a difference in the tension within the network, it's a homogeneous whole. Because of this difference in tension in the fascial network, which positions bones and nerves and blood vessels, all bodies are different, and we can't expect to find the nerves in one body in the same place that we would find them on another body. Also, because of this fascial continuity, it's possible that imbalances in one area of the body will be transmitted to another area of the body, possibly far from the origin of the imbalance. The ubiquitous nature of fascia leads to the conclusion that there really are no such things as parts in the body. The fascia creates and holds a space for what we call bones, muscles, tendons, ligaments, hearts, and kidneys, so on. Fascia, the organ of form, gives a shape to all of these body components. While it may be true that there truly are no body parts and that the body is a continuous unity, that doesn't lend itself to working with the body from a myofascial perspective. As such, we have the descriptions of Western anatomy to guide our work, and we work with planes and levels and layers and such. The major components of fascia are collagen and elastin fibers suspended in a gelatinous ground substance made up of water and proteoglycans. The varying content of collagen and elastin determines the strength or flexibility of the tissue element. In other words, a tendon that needs to resist tangential pulls will have more collagen in it than the myofascia, which has to be flexible and will have more elastin fibers making it up. The gelatin-like ground substance will be the same in both cases. The ground substance can change phase from a gelatin to a more of a solution under shear pressure, much like taffy will elongate if you pull on it. This tendency to change under pressure is called thixotropy. You've probably experienced this thixotropy if you've ever sat in one position for a long time. The ground substance takes on the shape of your body sitting, and when you get up to move, you feel stiff. Hopefully, a few steps later, as the ground substance changes, you're able to move more freely. We call this warming up out of the stiffness. The ground substance responds more quickly to a shear pressure than it does to a direct pressure. This is why the angle that we approach the tissue in myofascial release work is oblique rather than at right angles, or orthogonally for you math majors. That was the overview, and we'll spend more time going over all of this in greater detail in the following sections. In this section, we'll take an overview look at range of motion, or ROM, and its basic principles. When I use the word joint in this segment, I'm referring to any of those places in the body where a known movement occurs, not simply the bony joints. In other words, the soft tissue joint of the scapula on the thorax is included as a joint for the purposes of this discussion. Range of motion is a term used to describe the movement of joints. It is measured as an angular motion, or degrees of movement. It is coupled in its movements. In other words, flexion is coupled with extension, and that extension is the opposite of flexion. Each movement couple is known as a degree of freedom. For instance, a joint that can flex, extend, as well as medial and laterally rotate has two coupled movements and therefore 2 degrees of freedom. There are 3 types of ROM: active, passive, and active assisted. The active ROM is the ROM the body is able to access at any given time. The joints may be restricted in their movement, but this is what is available for motion. This is the ROM that we are trying to affect with our work. We want to see an improvement in active ROM if that is possible. Here's a video of a horse in slow motion. Its range of motion is what its nervous system can access. This is an example of active ROM. Active assisted ROM is a combination of active ROM with an intervention from the therapist. The client takes the joint to its active range, while the therapist assists them in moving further into that range of motion. Active assisted range of motion is not available to us when we work with animals, if only because we can't communicate to our animal clients to control their movement. Passive ROM is the ROM that is available to the therapist while the client is passive. It's this ROM that is measured as a baseline for gauging improvement. Even though the passive ROM may be able to improve with the therapeutic intervention, it's not of real value to the client unless they can access it in their active ROM. Range of motion measurement relies on having a defined starting point and a plane of motion in which the joint motion is occurring. The range of motion of a bony joint is limited by its anatomical shape. This anatomical limitation is known as the anatomical barrier. If the joint moves past an anatomical barrier, there is a risk of a breakdown of the bone. Other barriers limit range of motion and are termed physiological and paraphysiological barriers. We'll discuss these in more detail later. In this animation, we see a medial view of the scapula and the humerus. The deltoid tuberosity of the humerus impinges on the acromion process of the scapula when the humerus is in full extension. To prevent bone damage, the shoulder rotates at this point. This is an example of an anatomical barrier to range of motion. One can see that a restricted shoulder, or one not able to rotate, will limit humerus extension and cause front limb short striding. This rotation is under active motor control during locomotion. We need to be mindful that this is not the case when we are passively stretching the front leg, and to not over-torque the humerus into the acromion process. Here are a couple of more examples of anatomical barriers. This is a segment of lumbar vertebra. You can see that the transverse spinous processes will interfere with each other in rotation. This limits the amount of rotation that is available in the lumbar spine. In this photo, we see a medial collateral ligament which limits the abduction of the knee. Skiers often damage this ligament in a fall when they exceed this anatomical barrier. Okay, so that was an introduction into ROM, and here's a summary of what we covered. And we'll go into a lot more detail of this in the segments that follow.
Their hip socket a little bit, and that's what that coming in and coming out is what is the problem when they have hip dysplasia. So this isn't range of motion testing, this is just me tissue testing. Let's see. Okay, let's go down the leg. We're going to look at the knee joint, or the stifle joint, and the setup for this is that the tibia, this is the tibia, here's the knee, the tibia is 90 degrees to the femur. Lay back down for me, Bubba. And there we go, right there. The movements again are flexion. Flexion is always bringing the joint closer together. You can flex 65 to 75 degrees. Extension from here to here. Extension of 65 to 75 degrees. And just like with the elbow, we should see very little hyperextension. So it shouldn't go past that point of the 65 to 75 degrees. Well, I've said that it's important to know that those numbers were only averages of a number of dogs, and not the dog that you're working with. It's also good to just keep them in mind for things like what is a hyperextension. If all of a sudden we have 180 degrees, you have a very hyperextended knee. And he wants to rotate in, but that's the next test. As a human equivalent is the ankle joint, and the setup here is a little bit difficult because we want the tibia at 90 degrees to the femur, and then we want the metatarsal bones here to be 90 degrees to the tibia. So we have this 90 degree thing here. And you should be able to flex that 65 to 75 degrees and extend it. Lots of extension. Anywhere from 90 to 110. So this will allow for a little bit of hyperextension. And then we have a couple of new terms. An inversion, it should be 40 to 50 degrees. An eversion, which would be 40 to 50 degrees. In the front, inversion and eversion are called supination and pronation. So you have to change the names. And again, you want to just check the metatarsal phalangeal joints and make sure those are nice and open. I'm pretty restricted. Let's get this. There we go. Because of the stay system, which we'll talk about, because of the stay system, if we don't have things opened up, we're not going to be able to get the tissue length we need to test. And you can tell by his breathing that this is not something he dislikes. Okay, so the key points: make sure you get the correct starting position and that you keep the joint in the plane that it opens and closes in, or extends and flexes in. So what we're going to do in this range of motion test in the shoulder is find the shoulder. What I'll find the scapula here for you. And what we're looking at is the range that the humerus here. So let's put a piece of tape on the humerus. So here's the upper arm humerus, and here's the scapula, the shoulder blade. What I want to do is find its spine, and here's the spine of the scapula. So we want to start off, we have a starting position when we're looking at range of motion, so we want to start off with this in this 90 degree position. Now we're checking the range of the humerus at the glenohumeral joint here relatively to the scapula. So we don't want the scapula moving around as we're trying to check this range. So take these off. One of the tools that you can use, that physical therapists and people use, is a goniometer, and this just tells us the what degree of angle things are at. And if I take this to here, this is at 90 degrees. You can get these goniometers online for $8 or so. I happen to buy this thing. This is a carpenter's tool. I bought this at Home Depot. I don't do a lot of range of motion measurement recording, and so I really don't need precise tools. Okay, so here we are, 90 degrees, humerus to the spine of the scapula, and what we're going to do is see how much range we have, how much bending we can get in this glenohumeral joint. And it should go anywhere from 80 to another 90 degrees. And he's just a little bit restricted. So let's use this coniometer, or whatever Home Depot calls this thing. And there's our 90 degree starting point. And if we bring him all the way back, I can get him to 30. So from 90 to 30 is a 60 degree flexion. Okay. Extension. Again, we don't want that shoulder blade to move. Extension should be anywhere from 85 to 95 degrees. And there we are at 180. So he's got 90 degrees of flexion. Oftentimes when you're doing this, you're actually making it, you're treating the thing. So now if we bring it back, he still has, he's got about 65 degrees now. And there's 80, 85 degrees of flexion. So just by doing this, we can open up that joint. One of the other things we want to make sure of is that we have the joint in the correct plane when we're testing it. And in this case, the flexion and extension happens in the sagittal plane. Well, the glenohumeral joint can also abduct, and it can do that 40 to 50 degrees, and then adduct. He has a fairly big chest, and so it's a little bit harder for him to adduct. Here, he should be able to do that to 40 or 50 degrees. Then we have an ability to do an internal rotation here and an external rotation. The key point here is stabilization of the shoulder and determining the accuracy of your starting point. So a 90 degrees humerus to spine of the scapula. And then if you want to measure it, you need a device to measure it with. And as we move this, it's getting better all the time. Okay. I want to point out that I'm working from behind the dog mainly because the camera is over there and you wouldn't be able to see what I'm doing if I wasn't. But I normally wouldn't want to be bending over the dog like this. It's not good for my posture. The next joint we want to look at is the elbow joint. And again, we have a starting position. So here's the humerus, or the upper arm, and the radius, the lower arm. There's two bones here, as you know. There's the radial ulna joint, and then so those are the two bones, the radius and the ulna. And this olecranon process here, the ulna forms this, and it prevents any hyperextension. If you can see where this hair loss is from laying on the carpet, that joint is locked. The bone is bumping up against the humerus here, and it's not going to be able to come back. So that would be hyperextension, and this is flexion. So again, for this joint, we start off with a 90 degree angle here. Let's use our little Home Depot device. Okay, so if we bring this over, there's 90 degrees right there. And then if we measure his ability to flex without moving the humerus, don't let the humerus move, his ability to flex is about 50 degrees, which is, let's see, he's got about 60. He should be able to get 70 to 75 degrees of flexion. So I start off again here at 90 and bring him out to full extension, and that looks like it's about 75 degrees right there. to his full extension. Actually, even a little bit more, almost 70 if I bring it completely back. So from here to there. Okay, so now he's got 70 degrees, excuse me, 70 degrees. There. So as you're working these joints, you're actually lubricating them because they are synovial joints. And just this testing of it is beneficial to it. I like to palpate the soft tissue because that's what I work with to see if there's anything that's restricting the movement as I'm working. And the triceps, which comes down here and attaches, is a little bit hypertonic. Is actually fairly good sized. Adhesion right here. If he were a human, I'd be asking him if he's feeling this someplace because that might be that's a trigger point there. I don't know what his reaction would be. Trigger points have to refer pain someplace else other than where they are. Okay, now we also have not an internal rotation or an external rotation. The name changes for the elbow, but it's a supination and a pronation. And I remember supination, if our hands like this, like his paws, if you're carrying a bowl of soup, your arm would be up, the palms would come up, and pronation is just the opposite one. So it's if you remember one, you've got the other. And we just want to test, again, starting at 90 degrees. His ability to supinate and his ability to pronate. And supination, he should get 80 to 90 degrees. In pronation, he should get 40 to 50. Okay. So coming further down, we're going to look at the range of motion of the carpus or the wrist joint. And again, I keep saying this, but when we're treating it, as we're evaluating it, we're actually treating it. And I'm cheating a little bit here by treating it. So the starting point is going to be the carpus, the carpus in line with the radius here. So the radius and the ulna. And here's the space in between those two. Right there. His extension should be anywhere from 20 to 50 degrees. Now, the best way to test this is to have the arm completely extended out. And if the dog could be laying prone, that would be even better. So if you had a handler, the dog's guardian is with you, and the dog was laying on its stomach, with the arm out, this is a better way of testing this joint. So here's the joint. And you can see he doesn't have a lot of extension. And then we'll go ahead and extend it out and flex it back. And flexion should be 155 to 160 degrees. These numbers are just averages. They don't mean anything for this animal. These are averages of dogs that are large, small. He happens to be a Labrador. You could go find the numbers for Labrador retrievers, I'm sure. But what we're looking for is where did the dog start and where does the dog end? So there we're getting much more extension. Now the carpus has another couple of movements, and that's going to be a little bit difficult the way he's laying for you to see, but I'm going to show you. These are called deviations, and so taking the bone this way and taking the bone that way. And so they're not rotations. There's not a lot of rotation happening, but these are deviations. So in a human, which is what this one is, we see, so here's a radial deviation and an ulnar deviation, radial deviation, ulnar deviation, and that's what we're looking for there. Pretty restricted. But this is actually very therapeutic, this range of motion testing. You can tell he's not going anywhere. Okay, so we'll go further down here into these metacarpal bones. So in the front, This is the carpus, and the corresponding joint in the rear is called the tarsus or tarsal joint. And then these metacarpal bones are called metatarsals in the rear. And if you have the joint we're looking for is between these metacarpals and the phalangeals. And so this is the metacarpal phalangeal joint. And there aren't any real good numbers or data on what we should be expecting here, but we want to get just an idea of the quality, if you will, the movement that's happening in here. So just going through and experimenting, making sure that there's no heat, no inflammation, no infusion in the joint, and especially that it's not painful. Now you're going to want to have the handler or the guardian controlling the head, especially the teeth of the animal if you're working with it. This happens to be my dog, so he's a pretty good boy around me. This is all very good, very therapeutic. Helps these joints a lot just to move them around. Especially if the dog is a city dog that's always on flat surfaces. He happens to be a country dog, so he runs around in the fields most of the time. But if a dog or a person, for that matter, is always on a flat surface, then these joints are not going to be moving as well as they should. And this is very good, very therapeutic. And teach this to the guardians. Yeah. Get that out there. Okay. Okay, so now we're going to look at the rear of the dog for range of motion, the joints in the rear of the dog. And he's a pretty relaxed puppy. To measure the hip joint is called the acetabulum. We need to reference the femur. So here's his, let me get a piece of tape. Here's the femur, and this is his pelvis here. It's not going to sit. We need to find 2 points. Point that would be called the point of the butt in a horse and in a dog. The non-technical term, obviously. This is the tuber ischium. And then the point of the hip, which is called the tuber sacral. There's a line between them, and we want the femur to be at a 90 degrees with that line. So let me use this tool to show you that. Bring this femur and bring that to 90 degrees right there. So that's our reference point for these movements. We're going to take, and more important is to just make sure his hip doesn't move while you're doing it. Bringing his femur into flexion, we should be able to come 70 to 80 degrees. And then holding his femur and bringing it out into extension, we should be able to come anywhere from 80 to 90 degrees, and you can see that he can, with some effort. And that's what passive range of motion testing is that I am putting in the effort. He's not doing that. Okay. Then we have a few others of movements in here. The hip joint has a number of degrees of freedom, if you will. It can flex, it can extend, it can internally rotate, it can externally rotate, it can adduct, and it can abduct. And we need to check all of those. Now, adduction is kind of what he's doing here. If I have this in the plane, here's the correct plane for testing, and I let it go drop down. Just by the weight, he was in adduction. And his adduction should be 30 to 40 degrees. And then if I bring it up and abduct that joint, not letting the hip bone move, it's going to be anywhere from 70 to 80 degrees. Again, these are all averages. This doesn't mean anything for this dog. Now we have an internal rotation, this, and that should be anywhere from 50 to 60 degrees, and an external rotation, and that external rotation should be around 90 degrees. So there you go, see that external rotation. Dogs can also bring their femur out. Going to look at how we can apply what we've learned so far in the strokes to the rear end of the dog here. And it's very important to open up the hamstrings, the lumbar fascia, which is back here, the gluteals, the quadriceps, and into the gastrocnemius, the calf muscle on a person down in here. We want this leg to be able to just move back and forth. So into protraction and retraction as easily as possible. The rear leg propels the center of mass by acting as an inverted pendulum. So if this point here, if the acetabulum or the hip socket were the fixed point and the leg were penduluming like this, we'd say that the foot was the end of the pendulum. But what actually happens is that the foot becomes the fixed point in locomotion, and then this point is moved forward, and that's a pendulum that's upside down, so an inverted pendulum. It's only inverted if you assume that this would have been the fixed point, I guess. So let's take a look at the application of the strokes we've learned for this. I like to work in the rear of the dog in two separate sessions. So I like to work the outside, if you will, the lateral aspects, the hamstrings, the gluteals, the lumbar fascia, all the quadriceps. And then I like to work the inside, so we would flip the dog over and we work the inside of the legs, all of the adductors, the attachment of the psoas into the femur, the top of the femur, and the lesser trochanter. And so usually just start off tissue testing, and here I'm just going to use a long stroke. Open up this fascia, this superficial fascia, in this whole compartment. Now we've done our range of motion testing, so we could have established some goals for our work here. Find my bony landmarks. Here's the point of the buttocks, tuber ischii, into the hamstrings here. He's not overly bad in his hamstrings, primarily because he hasn't been pushing through much with this. You know, the between the roached back, which I think is caused by a scar, rather than his leg coming forward, he hasn't been able to elongate in the spine, this rib restriction, and so he brings his rear end around himself, and you see that in the movement assessment portion of the video. These long strokes are really good for these muscles back here. Excellent. We've got to remember to work the other side. So we work one side and then flip the dog over and work the other side. Video, we've got to remember to do that. we bring them into, not really even, we can flex or bring them into extension, and still this lateral quadricep is pretty hypertonic. So we just sink in and follow the movement of the fish. There we go. That was the separation as the myofascia of two muscles that were adhered together came apart, and there it is again. So we just get some delineation in here using this. From a pressure point of view, if you want to know how much pressure I'm using, which really doesn't matter, it's probably enough to hold up a quarter or two, not that much. Wait for this tendon to open. There we go. Into the gastroc. Here's the gastroc. The medial part is pretty adhered to itself. So my fingers underneath are working like this. Pretty hot, huh? Now I'm just taking it between my two, almost a pincer movement, but it's still one of the, what I would call a stroke. Not a cross fiber type movement, no circles. Yeah. Hamstrings come up into this lumbar fascia. When I say his or not, there's not a lot happening here. Moved him around so we can see how to work with this leg while he's laying on the other side. What I'm going to do is just reach up in here and work with the psoas muscle as it comes down into this lesser trochanter of the femur. And I've asked the film crew to come over and make sure his head doesn't move. We want to go very, very slow in this area, very gently. We want to feel for any pulsations, a blood vessel, an artery underneath our fingertips. We don't want to be pushing on those. Yeah. And while I'm up here, so I'm just doing a compression. So if you see my thumb, I'm just doing a compression on the psoas at the trochanter. And then I'm going to see what's happening with these adductors and medial hamstrings. Now, his medial hamstring, the semimembranosus, is pretty fibrotic. I couldn't feel this on the other side from the lateral aspect, but I can feel it now. And a stroke. And come into the medial portion of the gastroc and the flexors here. And I'm just going to engage this barrier with a compression. Just ask this tissue to go a little bit more lateral. The important thing to me about this work is take your time, take the time to sink in, and then just follow the tissue in small strokes. And if the small stroke that you're trying to make is not being accepted, then just try a different angle. If it's an energetically efficient recommendation that you're making to the body, then it's going to be accepted. So just these medial quadriceps here. The patella is underneath my middle finger, now my ring finger. Good. So if you have available a cat or a dog, it's good to go ahead and palpate these ribs. But more importantly, or as importantly, is to palpate the space in between the ribs. And here's a rib here and another rib there, and there's a space in between these ribs. And that's the place where we'll be doing a little bit of work. Okay. Let's take a look at how we can actually find a rib dysfunction. The first thing we need to be able to do is feel the ribs, feel the inspiration. So there's an inspiration, expiration. He's kind of panting because it's pretty hot under these lights. And what we're going to do is just put our fingers very gently, about what it would take to hold up an American nickel coin or 5-cent piece. And as we feel that inspiration and expiration, we'll actually, almost in an energetic sense, feel the rib moving. And we want to go to more than one so we can feel that. If we have a rib that's stuck, so let's see if we can find one. He doesn't have. Here's one that feels like it's stuck in a inspiration fixation. So stuck open. And what I'm going to do is just, there we go, feel that rib. And I'm just going to go ahead and try and exaggerate the motion that the rib would make, you know, the wobbling motion. Opening, closing. Sooner we'll feel as a wobbling in the rib. The rib will actually be moving something like this. Now this is going to be pretty difficult because he's panting. And now I'm just going to put a direction back on that rib. Since it's stuck open, I'm going to ask it to close. And beneath my fingers right now is what we call in craniosacral work a therapeutic pulse. As this tissue starts to release. And there. Now in preparation, since we've got this rib lying down, in preparation for it to stay, we actually want to open up the space in between the ribs, these external intercostals, the fascia around the external intercostals. And I'm just going to use one of the long organizing strokes. Even though this tissue is, the fibers are oriented in this direction, or a little bit diagonal to that, I'm going to go ahead and just sink into that tissue and make sure this fascia is open. Because if there's a fascial restriction, then this rib is going to just go back to where it was, because that's the most energetically efficient thing for the body to do. Mm-hmm. I know, Bubba. Good. Okay. This roached back, this is a flexion in the thoracic spine. The technical term for this is kyphosis. And he's not able to come out of this flexion, and so this is interfering with his movement. Primarily, I think the reason for this happening with him is the scar area here from where he had a cancerous tumor removed. And that, I believe, is impinging on his ribs. So let's lay him down and talk a little bit about ribs and how to work with them.